Good morning, everybody's here. So I'm Alain Stépagnan. I'm a professor of hematology in the Faculty of Medicine. I'm the head of the hematology clinical lab in the Montpellier hospitals. So I'm very pleased to introduce the next speaker, which is Marc-Antoine Labeyrie. Marc-Antoine is a clinician, and more precisely, he's an interventional neuroradiologist in Paris, in Lariboisière hospital. And he's a former colleague because I used to work there. Marc-Antoine works on innovative endovascular therapies, on epidemiology of rare macrovascular causes of strokes, notably. And so he sees the thrombosis and blood in patients' brains. So I'm sure he's the right person to make this topic on thrombosis in the arterial domain. So thank you, Marc-Antoine.
Thank you very much, Alain and Frank, for inviting me in such a wonderful place. And it's an honor for me to speak about thrombosis, as I'm not a hematologist, but it's very interesting in my disease, the disease I treat. So I will speak about clinical impact of thrombosis in cervical and cerebral arterial disease. I come from Lariboisière Hospital, very close from Gare du Nord. See if you want to visit us. The objective of this talk is this talk will present typical situation where thrombosis is the main determinant of ischemic stroke in cervical and intracranial arterial disease with or without endovascular therapy. But the question is how the biologist and also the biophysicist could help the surgeon and also the patient, of course. And that's the topic of the talk. We will see in the first part, we have a short reminder of brain circulation. Then we will speak about ischemic stroke. And then we will see thrombotic causes of ischemic stroke. And finally, we will finish by my specialty, which is endovascular therapy. And we will speak about thrombotic complication in endovascular therapy of the brain. So the first part, the first important message is that brain is not heart. We have 10 times less patients than cardiologists. I think most of hematologists works more with cardiologists than with neurologists. And I think we are 10 years late compared to the cardiologists for any evidence about our treatment. So it's like a virgin field where you could help us a lot, and it's very interesting. Apart from mechanical thrombectomy, which is the treatment of intracranial occlusion, which was validated only in 2015. We have very few high-grade evidence, no consensus, no standardized protocol, and because of that, all is permitted. Is not true, of course, but you will see that absence of evidence provides some strange way to do medicine sometimes. And it's a center and operator-based medicine. Another very important thing compared to the heart is that brain bleeds, not the myocardial muscle, of course. And the vessel size is not correlated to the function. If you occlude a small artery of the heart, you will have a small heart dysfunction, but for the brain, small artery could be very, very eloquent. So it's not correlated to the size of the vessel. It's very important. And we will see that unlike the coronary disease, cerebral disease, vascular disease are more due to thromboembolism rather than local arteriothrombose occlusion, and it's very different. So brain circulation, I think most of you know very well these things, but just for perhaps non-physician student here, brain circulation is a complex collateral network of vessels ensuring, of course, oxygenation of the brain, neuron, and glial support tissue. As you can see in this cadaver silicon injection, you can see how dense and rich is this network of vessels. The main determinant of the flow and of the oxygenation of the brain is, of course, the diameters of the vessel, the pressure and density of vessel, hematocrit. We spoke about viscosity. Hematocrit changed the viscosity, and also the rate of O2 that the blood can transport. And of course, the partial pressure of O2. So it's very simple, but it will be interesting for us later. Very, very simply, the anatomy of cervicocephalic arteries is, I think you know that. We have 4 cervical arteries, 2 carotid, 2 vertebral arteries arising from aorta and entering the skull at this level. And in the skull, you have 3 cerebral arteries, the anterior, middle, and posterior. Okay? The diameters of this artery are here. It's quite small artery compared to the coronary artery. This artery network has so many collaterals at each level of the neck, of course, the skull, and the most known one is the circle of Willis. As you know, as you probably know, the circle of Willis joins the 4 arteries I spoke about, carotid arteries and vertebral artery together. And you probably know that if you occlude the carotid artery, only a small rate of patient would develop ischemia because of this circle of Willis. I think less than 10%, if you can try, of course, but with the contralateral hands like that. If you have a palsy, you stop. Another collateral which is interesting to notice is the leptomeningeal artery. There are very small arteries at the surface of the brain, and they communicate together. And if you occlude proximally one cerebral artery, you will have this kind of anastomos, possible collaterals. And what is interesting is the same that for the circle of Willis, these collaterals do not depend on, vascular risk factors or things like that. It's congenital. You're born with or without good collaterals. And this is a mice murine model with different race of mice with lots of leptomeningeal collaterals and less. You can observe that. And if you do an occlusion of the middle cerebral artery in this mice for 1 hour, exactly the same, you will have a small infarction in this rich collateral network and a bigger infarction in the other one. As you know, the vessel of the brain, there is an auto-regulation of the brain circulation. Why? Because arteries, and even very small arteries, we will speak about that later, can constrict or dilate depending on many triggers like mechanical, chemical, even neuronal activity. There is a neurovascular coupling, meaning that when you use your brain for a task, for instance, you will have a local vasodilation of the small vessel to have more oxygen, more blood and more oxygen in that part of the brain. And this auto-regulation is possible in big arteries that we spoke about a few slides and previously, and because there are muscles, as you know, in the wall of the artery, but there are also pericytes at the entrance of each capillary, which has a kind of muscle cells, but it's a single cells that can open or close the capillary very quickly. The brain and heart take priority over the other organs. They are vascularized systolically and diastolically with low resistance. It's a Doppler, it's the velocity of the blood into the cerebral artery, and you have the systolic peak and diastolic. Compare with the skin, for instance, you have just the systolic peak and quite no vascularization during diastole. In normal condition, the heart input is oversized for the brain, and that's why the brain constricts in normal situation to adapt the flow, because you don't need so much pressure coming from the heart. So now let's speak about ischemic stroke. Ischemic stroke, you know that because it's quite simple. It's due to the occlusion of a vessel of an artery of the brain. And when you occlude a vessel because of collaterals, you could go into your destination with longer or not time. And if the time is too long, if you can't reach your goal very quickly, you will have a risk of ischemia. So there is the core, and there is around the core the penumbra, which is the part of the brain which doesn't get enough oxygen to function, but which is not in fact, and this is the penumbra that we try to recognize to improve the prognosis of the patient. Because of course the cord infarction, the brain is dead, and there are no use to recognize in that situation. How can you get a cerebral ischemia? There are three main mechanisms of brain ischemia. We will speak more particular in of the regional ischemia, which is the occlusion of a vessel of the brain. This is the typical situation. You have a clot, and you occlude, for instance, the middle cerebral artery here, and you have an infarction visible on the MR. This disease is observed in about 100 people a year in France. So it's quite frequent, unfortunately. And there are many ways to occlude an artery, and three different mechanisms of occlusion are embolism coming from heart, for instance, or neck vessels, stenosis due to different mechanisms. We will speak about that later. Atheroma, dissection, spasm, vasculitis could provide a stenosis, and it's what we will speak about, thrombosis. And in most of the case, these three mechanisms are associated together. Global cerebral ischemia is not due to an occlusion of intracranial vessels. It's an issue with the cardiac function or the volume of blood. I speak about relative volume of blood because you have the ratio between the volume of blood and the volume of the vessel, which is very important for maintaining a good arterial pressure. The intracranial pressure, if the intracranial pressure is too high, the arterial systemic pressure won't reach the brain. And of course, the lung, because you have hematosis of the lung, which if you have an hypoxemia, you will have a brain damage, of course. And also, if you have a hypo CO2, which is called hyperventilation. If you do that, we spoke about that in the restaurant yesterday. If you do that, you have a hyperventilation, you have a hypo CO2 in your blood, and it's a very, very intense vasoconstrictor of a blood vessel. And also, you have microcirculatory ischemia. You could have stenosis and thrombosis also. We will speak more especially about regional ischemia, and the question is how to treat the occlusion. First, you know fibrinolysis, and we call it thrombolysis with recombinant tissue plasminogen activator is the drug we use to put the clots chemically out to recognize the artery. I won't speak about the way the TPA works, because I think you have already lots of talk about that. But what is important is the comparison between TPA and placebo, which shows a benefit, clinical benefit of TPA compared to placebo, with less patient with disability. But as you can see, if you imagine that 0, 1, 2, 3 is the less disabling patient, the difference between both is not so big. So that means that TPA is good, but it's not magic. There are many reasons to explain that the TPA is not magic. The first is, if you recognize already infarct part of the brain, you can't cure infarction. So it works only if you are very early in the process to recognize the penumbra. And that's why we say time is brain. We can see that thrombolysis works, is beneficial for the patient till a certain point at 4 hours and a half. And after, you will have more complication than benefit. And one of the worst complications is the bleeding. The second way to recognize the artery is the mechanical thrombectomy. The mechanical thrombectomy is a procedure, an endovascular procedure, where you enter the vessel, the artery, and there are several different approaches, and some of them are totally now not more used because they have no benefit. For instance, the injection of fibrinolysis directly in the contact of the clot doesn't work. It's complicated to understand why, because you could imagine that you have a higher concentration of fibrinolysis against the clot. But it's probably true, but you have also more complication because of the navigation into the vessel. So it doesn't work, and we don't use it. You have such strange devices like a pigtail, doesn't work with a high rate of overrate of death by using this device. And the new tool to catch the clot is the stent retriever. The stent retriever is like a stent, but still joined to you don't deploy it definitely. You deploy in the artery and you pull it outside the vessel, and the clot is catch by the stent. I will explain you later how it works. And the last technique is the thromboaspiration, which is much easier to understand. You have a big catheter aspirating the clot directly in the contact of the brain. All of these devices have been validated very lately. If you look at at this one, 2014, 2019. So it looks quite simple, but because arteries of the brain are very fragile and they can bleed, it's not so easy to demonstrate the benefit of these techniques. And if you compare mechanical thrombectomy versus thrombolysis, you can see that it's not versus thrombolysis, sorry, mechanical thrombectomy plus thrombolysis versus thrombolysis alone. You can see a very interesting shift between both techniques in favor of thrombectomy. The procedure is performed in a kind of theater, is an angio suite, like in cardiology, with X-ray making the body transparent, and you navigate with a big catheter into the carotid artery, into the neck, and then with a smaller catheter, you cross the artery which is occluded. Here it's the middle cerebral artery, is the location, the most frequent location of occlusion. You cross the occlusion, you deploy the stent river, sorry, and you pull back the stent. The stent is an auto-expandable steel or nitinol stent, and you deploy, you pull back it without resheathing it into the microcatheter. You let it open and you pull back the stent. And how does it work? It's just because it's like a trivet, like that. When you put the stent against the clot, the quadrat stitch the clot, and when you pull back, the quadrat becomes thin like a lozenge, and you can catch the clot like that. And so you have an example here, you have an occlusion here, and a recanalization after one pass of this kind of stent river. So you have two ways, two approaches to recanalize, and we frequently combine them, the fibrinolysis and the thrombectomy, to recanalize the artery. And as I told you, it's not atherothrombosis, is embolism in 90% of the case in the brain. So it's very the contrary than heart and coronary disease, where you don't have any embolism, you just have local arteriosclerosis and atherothrombosis. Here it's just it's embolism into normal arteries. What could we improve? So what could we improve to improve the rate of recanalization? And there are many, many works on study on thrombus composition, because we observed that some clots are very easy to catch and some others are very difficult. And especially the clots, the red clots with lots of erythrocytes are easy to catch, rather the one with a low rate of erythrocytes. We speak about a white clot or a platelet clot, but there are platelets in both. The difference is more in the erythrocyte content. Are very stiff and difficult to catch, and also to fibrinolyze. So it could be interesting to predict at the before the recanalization which kind of clot it is. Some people have tried by imaging. There are very simple imaging that you can have in many patients, like susceptibility T2 susceptibility magnetic sequences, which show like this kind of artifact when you have a high concentration of erythrocyte because of iron content of into the erythrocyte. But it works a little bit. You have much more elaborate imaging that are not available in clinical practice. And you can also analyze, but it's not useful before the recognition, but you can analyze the clot after when you catch it and to confirm the composition of the clot. And it could be useful for finding the origin of the clot if it comes from heart or another things. What could you improve also is to better understand why the fibrinolysis doesn't work so well. That many patients with big clots where fibrinolysis doesn't work at all. And this is a very interesting study from Di Meglio, which shows that the clot is not homogeneous. You have a shell with fibrin, DNA, the net, platelets, and this shell around the core is much more difficult to be treated by fibrinolysis. So it's very interesting for targeting the fibrinolysis with other treatment like DNAs that could improve the clot lysis, for instance. What could we improve also? We speak about proximal occlusion, but what happens in the small vessel? And we know that in small vessel after a proximal occlusion, you have also lots of mechanism, inflammatory mechanism with leukocyte and things like that. But you have also thrombus of small vein and very small vessel. Here you have aggregation of erythrocyte in the vessel. And this aggregate, even if you have a proximal recanalization, you won't have a microcirculatory recanalization. That means a reperfusion. And this is very interesting. Why? Because you could treat this microvascularization occlusion with different treatment. For instance, in this murine model, we have compared a proximal occlusion with a mechanical monofilament in mice with placebo and in mice with thrombolysis. And mice with thrombolysis have a lower volume of infarction. Even if there are no proximal clots, it's just a mechanical occlusion, you know. And some studies have compared in human mechanical thrombectomy alone without fibrinolysis versus mechanical thrombectomy plus thrombolysis. And there are no benefits to do just mechanical thrombectomy, probably because the fibrinolysis is useful for microvascular occlusion, and it's very, very interesting field of research. So now let's speak about thrombotic cause of ischemic stroke. There are, of course, many, and I will just speak about most known causes. And the first, the most frequent one is, of course, atherosclerosis. I won't speak about heart embolism because it's a different topic. So atherosclerosis is 20% of cervical atherosclerosis is 20% of cause of the large vessel occlusion and 10% of intracranial cerebral artery occlusion. The most frequent location, as you know, is at the neck, in the carotid artery, the origin of the internal carotid artery, which is called the bulb, for very different reasons, but there are rheologistic reasons. And what is important is that atherosclerosis, there are different steps in atherosclerosis. Just a thickening of the the wall of the vessel. And something very important in certain patients, in some patients, is the intraplaque hemorrhage, making the stenosis, which is sometimes quite the narrowing, which is sometimes very severe, making it in few minutes much more severe because of this bleeding into the plaque. But the most important thing is also the rupture after the hemorrhage. You can have a rupture of the antima at the place of the bleeding, and this rupture is the cause of the thrombosis. So if you look at the three different mechanisms of stroke in arteriosclerosis, the first one is the purely thrombotic cause due to plaque ulceration. The second one, there is just hemodynamic cause stroke. There are no thrombus, just because you have a very narrow stenosis and not enough flow downstream the stenosis. You have no clot. And the third is a kind of mix between the two previous. You have no ulceration, but you have a very low flow, and because of this low flow, you have a thrombosis, which has probably a very different mechanism of this. We will speak about that, because this is a fast flow thrombose, and this is a low flow thrombosis. The question is why it is important to analyze this different mechanism of ischemia, because you will adapt, of course, the treatment to the mechanism. If you want to prevent the thrombosis, you will use antithrombotic treatment. If you want to remove the clot, if there is a clot, you will use fibrinolysis or thrombectomy. And if you need to restore the flow, you will recognize with different techniques, stenting, balloon angioplasty, endarterectomy, and so and so. And sometimes you don't want to remove the clot, you just want to trap it without recanalizing the artery. And you can occlude the artery. It works very well to avoid any further migration. So you can see here an illustrative case of a patient, a 60 years old patient who developed right hemipulse and aphasia due to this infarction of the brain. If you look at it's very difficult when you are not used with this kind of picture, but you have just to imagine that this is the carotid artery and it stopped here. Normally, it continues until the brain, and there is an occlusion of the internal carotid artery. So, as I explained, we try to cross the occlusion. We don't know that it's a stenosis due to arteriosclerosis. It could be a clot due to a heart embolism, but we have to cross the occlusion. So with a guide wire, we go into the occluded carotid artery till the cerebral artery, and we do a thrombectomy, and we recanalize the middle cerebral artery. But if you look carefully, it's very difficult to see in this picture. The artery is not totally normal, but we continue. If you look also, you have just one middle cerebral artery. You don't have the anterior cerebral artery, so we recanalize also the anterior cerebral artery. The same process. We cross the occlusion, deploy the stent reaver, pull back the stent reaver with the clot. Okay? And when we do that, the result is not very perfect. As you can see, the artery is very narrowed, and you have very low flow downstream this strange image. This is a stenosis. And you also have a stenosis in the artery. You have the middle cerebral artery you have previously recanalized. And by waiting a little bit, the middle is still a frontal view. The middle cerebral artery occlude. And this is typical way, this is the typical thing which happens in stenosis, intracranial stenosis. You can remove the clot, but it reoccludes very early. And in that situation where you have a severe narrowing, a severe stenosis, the clot removal is not enough, and you have to reopen the artery to restore a good flow. And to restore the flow, we perform not a thrombectomy, but a balloon angioplasty. So we inflate a small balloon into the stenosis, and after we put a stent. Why we put a stent? Because the balloon, there is a risk of recoiling after the balloon angioplasty, so we have to put a stent in that situation. We also do the same with the anterior cerebral artery, and at the end we have a perfect recanalized cerebral artery. And the stroke, the infarction is located at the same place that the previous MR, and there are no extension of the infarction in the penumbra, of course. Yes?
So in this case, so it's the clot that in a sense arrived and then the stenosis after, or there was a stenosis that basically made the clot occur,
yes.
And by recanalizing you just discovered that this part of the artery was basically stenosing, and I don't know, its tension state or whatever is very different.
Yeah. We discovered that it's a stenosis because when at the vessel imaging, all is occluded. So when you arrive to recognize the artery, you don't know if it is a thromboembolism, that means a clot into a normal vessel, or if it is a clot on a stenosis.
So
and
basically,
this patient had a stenosis, and I don't know which is the mechanism between these two situations, but he had a atherothrombose on an ulceration of the plaque, or because the plaque was very narrowed, you have a low flow and a clot because of the low flow. I can distinguish both because the arteries are very tiny, so it's impossible to analyze, if there is an ulceration or not. For big artery, you can see the ulceration. You can see something like, a hole in the wall of the artery. But here we are in one or the other situation.
So having a test for you of the tension state of the artery will be fantastic before opening or even doing something, not just having the image of...
It will, because this is... The treatment of this occlusion is exactly what performed the cardiologist in 98%. Oh, what happened?
Wait, it will come back.
Okay, in 98% of the case, it's mean angioplasty stenting. Okay, and we do it in less than 5% of the case. We do thrombectomy, which is totally different because it's clot on normal vessel. Yeah. If we could, and why it could be very interesting for us, because angioplasty stenting is good for coronary disease, but very dangerous for artery of the brain because it bleeds. And that's the big issue. And rather than thrombectomy is validated with a very high level of evidence, angioplasty of stenosis, it's absolutely not validated because of the danger to have a rupture of the artery or a bleeding of the brain distal to the lesion.
Thanks.
So, yes.
Can you go back to the slide where you had Sorry. No, you mentioned before that you have rethrombosis. Okay, here. Where are we here? are we in the carotid artery or?
No, it's a general case. It could be carotid artery in 20% of the case,
Yes.
or cerebral artery in 10%, especially in Asian people.
Okay.
So in the case I show you previously, we are in stenosis of cerebral artery, not cervical
okay.
artery.
So my question is, do you see often rethrombosis in this case, or is it extremely
Quite
rare?
all the time, even under antiplatelet, and even with tirofibin, which is quite
good. So I've asked this question to many neuroradiologists recently, and some of them tell me that it does not exist. They don't see rethrombosis. So why is it that in some centers you observe it? Is there anything special you do?
That don't they do a thrombectomy that remove the clot and
Yes.
don't do angioplasty after.
I mean, I've asked.
Without angioplasty, it will occlude very, very frequently. If you do an angioplasty with or without stenting, we could discuss about that. Is the stenting useful? Or I could tell you my point of view. But if you don't do an angioplasty, if you just remove the clot, you could imagine that the stenosis is not so severe. So with a very good antiplatelet regimen, you could imagine that the ulceration won't produce a new clot, so
Yes.
it will be patent, it stay patent. But in most of the case, cerebral arteries are very, very tiny, and the stenosis are very severe when you have this kind of clot, and it could be also this phenomenon. And in that situation, you recognize if you don't reopen the artery because of the low flow, because of the ulceration, also probably because of the intimal injury during the thrombectomy. Of course, you will have a high rate of reocclusion. Not 100%, of course, but it's very frequent. And I think in most of the centers, everybody will remove the clot and then do an angioplasty and stenting. So why the stenting is not for the recoiling of the stenosis. The stenting is useful because when you do an angioplasty, you broke you broke the plaque, and you have a dissection of the artery in 80% of the case. And a dissection, it's a flap, and you have blood into the antima and the media, to be simple. And if the flap is not with the flow enter the flap, you can have an occlusion due to the dissection. Very, very. I have a wonderful case where you do an angioplasty, you stop, there is a dissection, and the artery reocclude not because of thrombosis, but because of the dissection. So the stent is just useful to avoid the dissection to be occlusive.
Okay.
To my mind.
Okay.
Yeah.
Just two more very, very rapidly. First one is we talked about thrombectomy. Do you see also rethrombosis when you use thrombolysis? And the second one, based on what you just said, it would be fantastic here to use an antiplatelet agent, no?
Yeah. But we will use it because we use a stent also.
Yes.
We frequently do an angioplasty, and before, because I was a little bit afraid to do a dual antiplatelet regimen during the procedure with a patient with an infarction, I did an angioplasty, and I put a stent without deploying definitely. And I waited a little bit to see what happens with just single platelet, just aspirin, intravenous 250 milligram. And in many cases, because of the stent, because of the intimal injury, because of the ulceration, the likely ulceration, we can't see it, of the plaque, we had a thrombose of the stent. So now my protocol is, when I know that it's a stenosis, I always do a dual antiplatelet, intravenous antiplatelet therapy before putting the stent. And like that I have no occlusion of the stent. I speak about cerebral artery. For cervical artery, which are much bigger, it's a 4 and 5 millimeters large. Here it's just 2 millimeters large. You could imagine to use just single antiplatelet. But in 20% of the case, you can see the thrombosis on the surface of the stent. In few minutes, you can see it's like around the stent, and you have to use sterofilm. But it's not without any danger, of course. I will show you a case. Just a funny disease. It's not so frequent, but it's funny for I think, hematologists, because it's the carotid web. The carotid web is a kind of intimal flap in the bulb, and it makes this part of the carotid artery like a auricle of heart. It's a place where the blood is very slow and stay here for a long time. Sometimes 30, 40 seconds you have this is contrast injection, but here the contrast stays at the same place in these recesses for a long time. And we know that because of this lesion, you have no ulceration, no intimal lesion. It's just a question of flow. Because of this low flow inside the artery, even if it is an artery and not a vein, aspirin and even what you want has antiplatelet doesn't work at all. The patient recur, and it's very, very dangerous because it's in young people, and the rate of recurrence under aspirin is very high. And in this patient, we know that anticoagulant is better, works very well, but it's dangerous for life. Stenting is very useful because the stent, trap this small part where the blood is very slow, and you can also take off this flap by endarterectomy. And just look at this injection in the carotid artery, and look how long the blood stay in this small part. And you can understand why antiplatelet doesn't work, because it's a slow flow and not a fast flow like in normal atherosclerosis thrombosis. This other disease is quite rare too, but very interesting also, I think, for you, because it's a thrombus in the same place, but you don't have the flap I showed previously. It's just a thrombus. It's strange that the thrombus stay here and does not migrate in the brain, and it's quite almost in women with iron deficiency and severe anemia, which is you know that much better than me, a high risk factor of thrombosis. And at the beginning, it's very difficult to distinguish if it is a atherosclerosis or not, but we know it because after 1 month under anticoagulant, the vessel is normal, okay? And this is an interesting disease. And just to finish about the thrombotic cause of ischemic stroke, there are several others, but I speak about the most frequent, is the intra-arterial thrombosis. And it's very rare. And the Professor Hunt spoke about this in COVID patient and after vaccination. And we have seen such. You have here the normal left carotid artery, and here the right one, where it's a CT scan, and you have a clot, a big clot into a big artery. The diameter of the vessel is about 8 millimeters, so you can imagine the clot. And the artery is totally occluded. Here you have the clot, and you have nothing on the wall. It's not a disease of the wall. It's a disease of the content of the blood. And here you have the thrombus, the clot, and you have the removal of the clot by the surgeon. So this purely intra-arterial thrombosis without any visible intimal injury are have been seen just during COVID pandemics, and it's very rare to see it now. So I will speak now about thrombosis in endovascular therapy. I will use the most frequent treatment we do in endovascular therapy in neuro, which is the treatment of aneurysm. As you know, aneurysm are a kind of a pocket into the wall of the artery, because there is a disease of the wall, a focal disease of the wall, making this protrusion called aneurysm. And the danger, of course, is that there is a bleeding, perforation of the aneurysm, making a bleeding not into the brain, but into the space, the subarachnoid space where the arteries are located. And you can see on this CT scan, the white is the blood around the brain, which can cause many, many troubles. Aneurysms are very frequent, 3% of the population, but subarachnoid hemorrhage are very rare. It's one for, not so very, but it's quite rare, one about 10,000 patients a year. Perhaps a third of them die because of this disease. So there is a bleeding of the aneurysm, which is very short, for 5 or 10 seconds, and it stops. And if it doesn't stop, the patient is dying. So when you see the patient at hospital, there are no more bleeding, okay? And you have to occlude the aneurysm to avoid a new bleeding. And you have many ways to occlude the aneurysm. The neurosurgical clipping is the historic way to occlude the aneurysm, but in 90% of the case now, we use endovascular technique to occlude the aneurysm. The most simplest one is to use a platinate coils that you introduce into the pocket, and you detach it, making a kind of a ball into the aneurysm, and the blood can't enter. Because it's metal, you have also a clot around this, and but it's not intraluminal, it's intrasaccular clot, so it's okay, because the aneurysm does not circulate anymore. Sometimes we need to use a stent. It's an auto-expandable, still on nitinol stent. Why? Because if the neck of the aneurysm is very large, you can imagine that the ball could go into the lumen of the artery, and the stent is useful to maintain into the aneurysm the coils. Some coils, some stents are useful. The name is flow diversion stenting. They are very useful because it's kind of intelligent, smart stent, which make the flow in the blood flow into the aneurysm lower, but let the flow in normal artery normal. We will speak about this stent later. And the last device to occlude the aneurysm is this kind of device. It's named intrasaccular flow diversion. The procedure is quite the same that for thrombectomy. You have generally femoral artery access. You put a big catheter into the neck, and after you use a smaller catheter to enter the aneurysm, to put the coils, 1, 2, 3, 4 coils, and sometimes to put a stent. After the procedure, you occlude the vessel here, the femoral artery, with a kind of plastic anchor, and here a collagen that you push against the whole of the artery. But what about the complication of this treatment? What we know is that the simplest way to treat the aneurysm is the safer way also. Coiling is associated with permanent morbidity and death of 2%. Stenting, 4. Flow diverter stent, 6. But on the contrary, the recanalization rate is higher with coiling, lower with stenting, and very lower with flow diverter, very high with intrasaccular flow diverter. So recanalization is not a good thing, because you have to operate a second time the patient, but it's something not so awful. But you have to understand that if you use a stent, it's more risky, but probably more efficient. As you can see, you don't use antiplatelet when you are just intrasaccular, but when you use a device and you put a device into the lumen of the artery, you need antiplatelet, and most frequently it's a dual antiplatelet therapy for 3 months and single for life. We don't know if it is for life or not. And for flow diverter, because the risk is higher, is dual for 1 year in some centers and single for life. And for intrasaccular flow diverter is a kind of mix between coiling and stenting. You have just single for 3 months. As I told you, aneurysm repair is always preventive. There are no ongoing bleeding when you treat the patient, although the patient is dead. So that means that aneurysm is rarely a bomb. And even for unruptured aneurysm that you could find for other reasons, you do an MRI because you have headache, for any other reason, you are a migraine or what you want, you discover an aneurysm, the risk of rupture of this aneurysm is actually very, very, very low, especially under 7 millimeters. Why I speak about that? It's because you have to compare the risk of the procedure to treat the aneurysm to the natural history risk of bleeding, and to understand that because there are no evidence or very few evidence of what we do in this specialty, there are some interpretation of this time very different according to the surgeon or the centers. And it's a real question, because you could be this guy entering very nicely in this wonderful hospital and dying after the procedure. So what is the risk that you would accept for you to be treated? And why I speak about that? Because you, hematologist or biophysicist, you could change with us this rate of complication, which make all the difference between the 5, 10, 15, and 30 years. And the question is how to make this the more beneficial for the patient. So very few cases to show you this kind of complication. You have a patient with a subarachnoid hemorrhage. It's a female, no medical history. You have a very, very, very tiny aneurysm, little aneurysm, small aneurysm, sorry, of the, you can see just 2 millimeters large aneurysm, and we enter the artery, enter the aneurysm to put a coil, okay? Under half dose of heparin. Why half dose? Because when there is a bleeding, recent bleeding into the brain, we prefer to put half dose rather than full dose to avoid, rebleeding of the aneurysm. But we don't know if heparin makes the aneurysm rebleed or not. And what happened? Very few minutes after the second coil, you have a thrombosis of this small branch. But as I told you, small branch in brain could be very eloquent. So you can't say, oh, it's a small branch, I let it occluded, it's not a problem. And here you have the non-subtract, you can see the small coils, and the small branch. Here you can see the clots. So what are your hypotheses for local thrombosis? Why is there a local thrombosis? And you will see that this patient has also another thrombosis in another territory. We will speak about that later. Hypothesis. The first hypothesis is that you put a first coil, the aneurysm thrombose, and you put a second coil, making, like a full glass. If you put more something in the full glass, you will have water outside. And if you put a coil into a full clot the thrombose aneurysm, you will have a kind of reflux of the thrombus outside. This is the first hypothesis. The second, we were here with a microcatheter, and it was not so easy to enter the aneurysm, so it could have intimal injury with platelet activation in this patient, with the bleeding into the brain. There are probably an inflammation. Okay. There also could have a coil into the artery because it's metal. You have activation of the plaquette, but here we don't see any part of the coil into the artery. It's not this hypothesis. Or you could have also, because narrowing of the lumen of the artery due to the coiling, if we do a bad coiling, with flow reduction. But here it's not the case because the artery looks normal. So our hypothesis was intracircular clot extrusion. The second coil was the clot. Was too much. We should have stopped the procedure after the first coil. How can you treat that? Aspirin, full dose of heparin, that means 70 unit per kilo. You increase the arterial pressure and you wait. It doesn't work. You add tirofiban, for instance. You could be cangrelor, but you put dual antiplatelet. No stent because there are no lumen narrowing in that mechanism of clot. Okay, and in most of the cases it works. Okay, so this patient had also another clot complication, but at the very, very beginning of the procedure, you have in this frontal view the carotid artery, anterior cerebral artery, middle cerebral artery. The aneurysm was here, and there is an occlusion of the middle cerebral artery. We were not inside. So the hypotheses are that the clot arises from the cervical carotid artery, probably because the guiding catheter, which is the big catheter, makes like a intimal injury or low flow in contact of the bulb. This part of the carotid artery has very frequently laminar low flow. And why I speak about that? Because in that situation, the mechanism of the thrombus is more low flow related thrombosis. And the treatment would be, to avoid this kind of thrombus, would be to provide, to prescribe heparin rather than aspirin or antiplatelet. Okay? We treat with mechanical thrombectomy, and the way to avoid this kind of complication is to use heparin in each case. The same patient, after recanalization, proximal recanalization, had small distal occlusion. We then use fibrinolysis to reopen the small artery, and at the end there was quite limited infarction, but with a slight disability. You have any question for this case? You have many different mechanisms of thrombosis, and it's interesting to see how you can avoid it depending on the mechanism. The second case, subarachnoid hemorrhage, an aneurysm that we can't treat with coils because there are no neck, okay? The patient has an external ventricular derivation, so it crosses the brain. It could bleed if you put a very high-dose antiplatelet therapy. And the only way to treat this aneurysm is to put a flow diverter here in the big artery to reduce the flow in the small. We put a stent under cangrelor and aspirin. Cangrelor, I will speak about this treatment. I think you know it. It's intravenous with very short life antiplatelet. So when you put the stent, we put the stent, the artery downstream was patent, but few days later, because the cangrelor was stopped for 1 hour for removal the external ventricular derivation to avoid any bleeding of the brain, there was no new bolus of cangrelor, and so finally a lower antiplatelet effect, and the artery, the stent occludes. the last case, quite the last case, patient with a big aneurysm, we put coil, stent, because the neck is very large. We do the control each year. At 3 years, the MR control shows no aneurysm, something strange into the artery. Probably the stent was not very well apposed. The patient is still under aspirin, and at 4 years, he developed a thrombus of the stent. Why 4 years later and not before, we don't know. And he developed a thrombus of the stent. And despite a mechanical thrombectomy, the patient died because of this very huge infarction. The hypothesis of this complication is probably because the stent, if it is not well apposed to the wall of the vessel, will never be covered by new intima, and it will be in contact of the blood for a long time. And even if there is very few metal in contact of the blood, there is a small risk each year to have a clot. And yes, the very delayed thrombotic complication with stent is quite rare, but it's possible. I finish in few slides just to show you thrombotic complication, but also hemorrhage complication. The patient has a big aneurysm, you want to treat it, but during the navigation with the guide wire, you have a perforation of a very small artery. And because the patient is under dual antiplatelet, aspirin and clopidogrel, with a test at VASP at 45%, there is a massive bleeding by this artery. In that situation, you have very few things to do. You occlude with a balloon proximally the artery, and you wait. And during this time, you antagonize the heparin and also give platelet 10 units in this patient. And the bleeding stopped, but there is an hematoma into the brain with aphasia in this patient. So it's a very severe complication. This last complication is a patient with a huge aneurysm here of the carotid artery. So in that patient, we put coils and we put stent. You can see the flow diverter stent here. It's very difficult to see because there is very few metallic opacity. And this patient had dual antiplatelets. I don't remember. Yes, it was prasugrel. So this is the aneurysm before treatment. Day 1 after the treatment, aspirin, prasugrel. Okay, the aneurysm looks a little bit bigger, but okay, it could be due to the coiling. But what is unexpected is at 1 month, you have a kind of rupture of the aneurysm, which here, the rupture of the wall of the aneurysm makes a kind of bleeding here, but fortunately this bleeding is located, and the patient has just headaches, no palsy, no symptoms other than very severe headaches. And how can you treat that? And it's impossible. You can't put more coils because it's at the bottom of the neck of the bag of the aneurysm. And the only way you can treat that is to stop the antiplatelet, because probably the hypothesis of this secondary rupture of the aneurysm is mediated by many things. The flow direction change. So in this patient, it was not the case because we put coils to avoid this kind of things, but some physician had a rupture of this kind of aneurysm after flow diverter, because before the flow diverter and after the flow diverter, the flow change and makes the aneurysm ruptured. You have many mechanisms, many speculation about the mechanism, but I think in our patient, the true explanation was that there was a wall inflammation related to the clot into the aneurysm that breaks the wall of the artery. Okay, what could we improve? Of course, we could optimize the antithrombotic therapy, and the problem, there are no recommendation, no standardization in our specialty, so it's where you could help us. To avoid to be too long, you have many different antiplatelets. Hematologists know them very well. The most used for dual antiplatelet with aspirin is clopidogrel, but there are some genetic, as you know, resistancy, and others have many different ways to work. What we could say is the prasugrel, ticagrelor, cangrelor, and all of them are more have a higher antithrombotic effect than clopidogrel, and the result is there are more bleeding with this treatment. So we have tried many things to optimize this antiplatelet therapy. Could we give just single antiplatelet with prasugrel or not? There are many studies showing that it could work. For instance, prasugrel versus dual antiplatelet could be better, apart from stroke. We don't know why. The length of the treatment, the longer the treatment, the dual antiplatelet is prescribed, the less stent thrombosis you have, but the more major bleeding you have. So it's very simple to understand, but you have to help us to determine this risk. The monitoring of the antiplatelet effect is very, very important. We use it for a long time with Alain, especially in our center. There are many ways to know the antiplatelet activity, and we are, even if it is very controversial in literature, we are very sure that it helps to avoid thrombose or bleeding in most of the patients. But it's not. It's still controversial, and many centers doesn't do this kind of test to know if the antiplatelet effect is enough or too high. You have some very interesting things. I think you have a lecture about that, so I won't speak about for a long time. Look, this picture. The guy looks so impressed by this wonderful effect. You know, you have a coating of the stent, making it less thrombogenic. It looks so wonderful, but all the study used to show a benefit of this under single antiplatelet regimen was negative. Why? Because as I explained you, there are many different mechanisms of thrombosis in a patient with a stent. You have, of course, metal into the lumen. If the stent is not well apposed, you will have metal for a long, long time. You will have also low flow in small division branches arising from the stent, and in that situation, single platelet is not enough to avoid thrombosis of this part. We could also imagine, because it's low flow, we could imagine something more like anticoagulant, but it could be dangerous to mix anticoagulant and antiplatelet, of course. So that's why this kind of stent won't resolve the problem of dual antiplatelet and the risk of dual antiplatelet. We could also better assess if the stent is well apposed or not, and this is the very interesting use of the intravascular imaging. Here it's optical coherence tomography. It's a kind of laser into the vessel, and you can see the antima and so and so. And here you have the stent, you know, the black things here. The stent is under the antima. the intima. But at this place, the stent is into the lumen. And you can imagine that in this patient, even 5 years later, under single antiplatelet, you will have a risk of stroke. So this is a very interesting tool. And so what could we improve? To decrease the bleeding risk, clinical score, parenchymal brain imaging, systematical digestive endoscopy, or systematical gastric protection. I won't speak about our protocol because it's like in the cooking, they are so different with other protocols, but we could speak later. And my conclusion is that endovascular surgeon need help for optimizing and monitoring the antithrombotic therapy, scoring the risk of thrombosis and bleeding related to the patient or malapposition of the stent, for instance, to provide definition, standardized protocols, and also to help us to distinguish the mechanism of thrombosis, low flow, intimal injury, or related to the device malposition. So many thanks.
Thank you very much, Jean-Marc Labeyrie, for your nice talk and to show us your universe, because you are swimming the whole day into a patient's brain and the blood and the clots. I'm always fascinated by this because I think it's really a tough job. So if you have questions, please.
Hi, thank you for the talk. It was great to see that there are a lot of things to do still. I would have probably tons of questions, but I keep it short. First, you talked about balloon angioplasty plus stenting. Do you perform it in all the arteries in the brain, or just the biggest? And which balloon are there balloons for neurovasculature?
Yeah, we do a balloon angioplasty till 2 millimeters large artery. Under 2 millimeters, it becomes dangerous, and we use non-compliant balloon angioplasty, meaning that you can increase the pressure into the balloon without increase the diameters of the balloon, because you will have with too big diameters risk of rupture of the arteries.
And do they work, or do you think that?
It works.
Okay.
It works, but it's dangerous.
And another question would be, you spoke about aneurysm and the neck and the formation of intima. Do you see formation of intima over the neck of the aneurysm, or? When the aneurysm is totally occluded, and especially with a flow diverter stent, you have a neo-intima. It's not exactly just endothelial cells. You have fibroblasts and things like that, but it's a neo-intimal membrane, yeah. In the best case, I think there are several cases, and probably the patient who died 4 years later had not this kind of protection again, and the metal of the stent was still in contact with the blood. And one information probably I didn't get it. Why you think that this heal, so surface treatment is not solving the problem due to the fact that the flow diverter can still obstruct the
because it looks good, as the picture shows it. But as I explained you, if the stent is not well apposed, you will have a kind of low flow between the wall and the stent, making a thrombus, whatever the thrombogenicity of the stent. It's just another way to have a thrombosis is low flow pathway, if I could say. And also, when you put a flow diverter on a small artery, a small branch, it's very complicated. But if the artery is terminal, it sucks, it aspirates the blood, and there is no risk of secondary thrombosis of the small artery. But if there is good collaterals, there is a competition of flow, and you will have, in the proximal part of this small artery, a very low flow, just because of the competition of flow, and you will have a thrombosis, even under antiplatelets. This is a risk, secondary risk of thrombose with flow diverter, and it is not because of the flow directly because of the metal of the flow diverter. It's just question of flow. That's why it's very important to distinguish what is flow mediated, intima injury mediated, or metal thrombosis.
And one last, you showed that in one patient the flow diverter was occluded in the end. How do you treat an occluded flow diverter?
Unfortunately, we discovered, it's a very recent case, we discovered it too lately, and we didn't treat it. We stopped any antiplatelet. It was too late.
But if it was to be treated?
If we were at the very early phase of the occlusion, for instance, the 5 or 6 first hours, we would have put a bolus of cangrelor, I think, to reach the good level of antiplatelet therapy, and I will have aspirate into the stents, but it's not so easy. Yes?
Hello. Thank you very much for your presentation. It was really interesting. I'm a postdoctoral researcher at the École Polytechnique of Paris, and I'm studying how great flow deceleration, blood flow deceleration, can induce platelet aggregation and thrombosis. Do you think that in some cases that you observed, this could be the cause? Of course.
I showed a quite rare disease, which name is carotid web, to show you that even in an artery, you could have venous-like disease. That means you can give dual antiplatelet in carotid web. The patient will have recurrence of thrombus without any intimal injury. So it's just because you have a very low flow in this part. And anticoagulant works very well in this disease, but the problem is when you are 30 years old, you can't have anticoagulant for life, because it's for life. But we have seen that more than the low flow, so low velocities, is more the fact that we have a change in the velocity, so higher velocity and then lower velocity. Okay, yes. When I say, you're totally right, I wanted to say low velocity rather than low flow. It's not the same, but I wanted to say low velocity is anticoagulant, fast is antiplatelet. For us, it's quite obvious, but you have to demonstrate that we are right. We're right, because it's just a physician feeling, I see. Okay, yeah. Thank you.
Hello, my name is Meltem from University of Tübingen. Maybe you have seen also my presentation regarding Candace? No. Okay. So my question would be, or I have two questions. First one would be, which types of flow diverters are you using? Are you using without any coating, or do you recommend a coating, or would you say, okay, it's also good to use without coating the flow diverters? That would be excellent question.
Every company change for new flow diverter with coating, so we don't have the choice now. It's not worse, of course. Could be a little bit better, but we use the same antiplatelet therapy.
Yes, yeah.
We didn't change.
Which did you recognize a coating, or there are different coatings? And did you recognize one coating type which is better than the others, or you didn't recognize any differences?
As I explained, Alain, we have a very different vision of biologist or biophysicist. We are in the macroscopic world, and for me, I choose the stent which has the best radial, force of apposition, because for me there are much more risk of stent thrombosis if it is not well, it is mal apposed to the wall, rather than something microscopic for me. And in my experience, I had no awful thrombosis with a normal stent, when I'm sure that it's perfectly well apposed. If you can imagine the coat stent with a good radial force, I would choose this stent, of course. But for the moment, the best choice for me is to use the
Thank you very much. And the other question would be, are there any biodegradable coils available, or are you always using metal, which is staying there the whole life?
In clinical practice, there are no this kind of coils, but people's works on it. I think it's not. I don't know why it could be interesting. I think coils with special coating, making a kind of protection against inflammation of the wall of the aneurysm, could be better. I don't know. A sirolimus stent used in cardiology. We use sometimes in carotid artery also. But coils with this kind of specific treatment could be very interesting, because the big issue with coiling is not so dangerous. 2% of complications is much less than other treatment, but there is a high rate, not high, but 20% rate of recanalization. If we could use coated coils to avoid this kind of recanalization, it will be wonderful. And what kind of coating, like prothrombogenic or antimitotic? I don't know. It's not my word, but I think in the future it will be perfect to put just one coil, no stent, nothing into the lumen, and the aneurysm will be a cure for a long time. It will be the best, I think.
Thank you very much.
But in the case of the, thank you very much, first of all, for the very nice presentation. In the case of aneurysms with a large deck, the coil is not enough. You have to put a stent as well, right?
Yep. Yep.
So it is doesn't. I mean, the risk related to the treatment is the risk of the coil plus the one of the flow diverter, or is it globally? You see what I mean? Because you have presented 2% of risk for the coil and 4 and 6, but you have 2 coil plus stents. Is it 2 plus 4, 2 plus 6?
Yes. When you have no choice, you are obliged to put a stent. In the case I show where the stent thrombose was this case. You can't put any coils. But more and more people use stent because it's easy. Okay. Easier to put a stent than a coil. And I think it's more dangerous because you have an intraluminal and dual antiplatelet therapy. It's not the same that nothing into the lumen and no antiplatelet. So the 4% is not 2% because of the coil and 2% more because of the stent is a global risk. I can tell you why, but the complications are bleeding, stenting thrombosis or things like that, and they are very, very severe.
Are you aware of any issue after maybe many years of after the implementation of rupture of a stent or of a flow diverter because the struts are submitted to cycle stress, and so maybe after many years it could break by fatigue. And do you believe it can happen?
Question. To my mind, I have only one case of a ruptured flow diverter stent in a cervical artery because of the torsion or the curve of the movement of the patient like that, but it's very, very rare because it's they are quite adaptable. It's auto-expandable stents, so it's not like in cardiology. You have a very balloon. It's very different than balloon stents, which are very they can't move.
Okay, thank you.
Is there
It could be good to have biodegradable stents, better than coils, because like that you have at the end a normal artery. Could be very good.
Okay, do you have any questions? Other questions? No. So thank you very much.
Thank you.
Marc Labeyrie.